Hello, and thank you for joining us for another episode of Matters of the Heart, a program brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. My name's Dr. Sunny Srivastava. I'm here with one of my partners, Dr. Kenneth Adams, and we're going to talk about, I think, what I will find to be a very interesting topic. Dr. Adams, I think, recently read a book that highlights some of the modern innovations or recent innovations of cardiology. So he'll take us on a little tour of recent history of modern cardiology. So I'm excited to hear about this. So I'll hand it over to Dr. Adams with that.
Thank you. What I've titled this is a brief history of modern cardiology. And a friend of mine, a classmate from medical school, Tom Lee, who was also a very prominent cardiologist in Boston, I don't know how he found the time to do this, but he met with probably the most famous cardiologist of the last 60 years, Dr. Eugene Grunwald. He met with him every couple months, sat down for a few hours, and went through Dr. Grunwald's history as a cardiologist. And Dr. Grunwald's history as a cardiologist basically parallels cardiology development since the 1950s in the U.S.
And just to interrupt, is Dr. Grunwald still practicing?
Yeah, so that's an interesting story. People come up to him and he says, yes, I'm in my still years. And they say, what do you mean your still years? I'm still practicing, I'm still researching, I'm still doing this, I'm still doing that. So he's got a bit of a sense of humor.
Yeah.
So as background, things have changed so dramatically since 1950. The way we approach diseases, the way we do research studies, it's dramatically different. We kind of understand the illness rather than just observe it. So, the giants of the old days, the well-known doctors, they would be able to list all the symptoms and signs that a particular disease had, but they might not know what's causing it. So an example would be rheumatoid arthritis, where you get a lot of swelling in your joints and your joints get deformed. You could certainly diagnose it, but no one exactly knew how to treat it. Now we know that it's an inflammatory process, and we've got a host of different medicines to treat it. So that's really changed. The other thing that's changed is we have comparison studies. So for an example, in cardiology, people who have what we call cardiomyopathy, a weak heart, sometimes they need defibrillators. And we had to prove that people with defibrillators did better than people who didn't get defibrillators. So we had a scientific study, and we showed it. So we're all now more evidence-based. We want to do things that have been proven. I think in the last 50 to 60 years, if any specialties had dramatic advances, it's been cardiology. Mm-hmm. It used to be that a heart attack was sort of just a bolt out of the blue. Like all of a sudden, no reason at all, somebody had a heart attack. We weren't thinking about the smoking and the lipids and the diabetes. It was all, mm-hmm. And we didn't, I think everyone listening to the show is going to know that we have ICUs and CCUs at hospitals. We didn't have them in the 1950s. They started coming around in the 1960s. And just having people in an ICU under critical care led to some decrease in mortality.
And prior to that, if you had a heart attack and were hospitalized, am I correct to say that the prescription was just lay there in bed?
Right.
There wasn't a whole lot offered, and really lay there in bed for a long period of time and go home and just convalesce as well. Is that
Yeah,
accurate?
Absolutely. You just would lay in bed for 3 or 4 weeks and let the heart heal. And now it's so totally different because we're getting people out of bed almost immediately.
Yeah.
So let me give you some background about Eugene Grunwald. I think, we in cardiology all know him because whenever he speaks anywhere, there's always crowds listening to him. But he came to the U.S. from Vienna. He was a member of a Jewish family in Vienna. He was born in 1929. In the 1930s, his family's business was taken away, and his father was briefly detained by the SS. The stormtroopers from the Nazi era. And maybe Eugene Grunwald's mother's a bit like Eugene. Anyway, she somehow convinced the SS to release her husband. She said, we run a textile store, and how do you think it's going to make a profit if you don't have the person here who knows how to run it? So they released him. But that was the handwriting on the wall, so they left. And they went first to England. They stayed there for a very brief period of time because it was still wartime in England. Mm-hmm. They came to the United States. So from this background, just being an immigrant, another immigrant story, he became the leader of cardiology in the United States. He was running the cardiology program at the National Institute of Health and then at Brigham and Women's Hospital in Boston. His career is totally intertwined with the developments of cardiology, and I'm going to try to show some of those major developments that he was the lead on. But I have a couple of cute stories about him from his education. So he finished first in his 8th grade class, so no surprise, he's a very smart guy. Then he went to Brooklyn Technical High School. So
what's a well-known school?
Well-known school, you've got to take entrance exams to get in. So he got in, but this was more of an engineering and an architect school, and he really wasn't doing well. He was getting Bs. You know, a lot of people would be satisfied with Bs, but his mother said to him, you know, you're not a B student. And she said, why did you think about medicine? So he did. He had some other relatives in his family who were into medicine. He thought that was a good idea. So he went to New York University in New York for college. Started at age 16, so that's young.
Yeah.
And then after 3 years at college, he was accepted to medical school. That's an interesting story in and of itself. There was, at that time, some discrimination in medical school admissions. And he was, I think, the last student accepted to his medical school class. So not an auspicious beginning. Yeah. But he was an incredibly hard worker and a very smart guy, and he ended up finishing first in his class.
Yes, it's usually a good combination.
Yeah.
So.
But there's an interesting story about one of his classes. They had recruited, the medical school had recruited a kidney physiologist to teach part of the physiology spectrum of the courses. So this teacher who wanted to come in and kind of show the students what he knew and who was the leader of the class. So he scanned the room. He his eyes happened to land on Eugene Grunwald, and so he asked him some tough questions about physiology. And he got all the answers. He knew all of it because he'd already studied it. And the professor was a little taken aback, but he slowly realized that this was an exceptional student. This wasn't the run-of-the-mill, medical student. So he went from NYU to one of the best residencies in the country. It was at Johns Hopkins in Baltimore. So that was one of the best places to train. It was one of the more modern hospitals. You didn't get in just because you knew somebody, which is the way a lot of people were getting into these programs at that time. You had to get in based on your qualifications and your research. And at that time, you had to essentially live at the hospital. Yeah. Hence the word residency. We do an internship and a residency. I think you and I both had residencies that were pretty intense, and we felt like we were living in the hospital. Yeah. But in his era, you actually did live at the hospital. Right. And he and some other students tried to change it, but they couldn't get the administration to budge. They thought it was very valuable to be there all the time because that's when you learn things. Yeah. So I wanted to shift gears a little bit now to just give some perspective into cardiology and some of the modern things that we do now. So we take cardiac catheterization for granted. We see patients in the office, we say, you need a heart catheterization. We explain to them what it is. We say it's very low risk. We've been doing this for a long time. But the first time it was ever done was in 1929. A urologist, someone who was studying kidney medicine, he decided that he was going to put a catheter into his heart. So he went up from the arm, which leads you into a major vein, and then back into what we call the right side of the heart. He took an X-ray to document it, and people thought he was absolutely crazy to do this.
And if I recall the story correctly, there's a lot of controversy about it where he had to, I think he had a girlfriend at the time, or his wife or something, and had to dupe her and essentially strapped her down so she wouldn't go tell somebody to stop him what he was doing. Or does that ring a bell to you?
That part wasn't in the book, but that may very well be true.
I've heard something, yeah.
People thought he was absolutely nuts to be doing this. Right. So that was kind of how catheterization first started, but really didn't take off for about another 20 or 30 years. The other thing that we take for granted now, we have a lot of heart failure patients, people who accumulate fluid either for a weak heart or a heart that's not relaxing enough to work right. And we take it for granted. We put them on, 4 or 5 different medications. They do well. Well, it wasn't quite like that in the 40s and 50s. There was one diuretic available, and you couldn't take it orally. It had to be injected into the muscle. So the heart failure patients would go in once a week to the heart failure clinic, get this incredibly painful injection, and then hope for the best.
Yeah.
When Dr. Grunwald was doing his residency in medicine, there was a Thursday night cardiology clinic. And this is where you could go to listen to patients who had interesting heart murmurs. I know when I was in medical school, we all sat in an amphitheater and we each had a set of headphones, and murmurs would be played, and we would get to know what they were like and what they meant. I'm not totally sure that that's done now, because now we've got cardiac ultrasounds that show us even more about the heart than we can
Yeah, I suspect
get by
that
listening.
we did something similar. It wasn't in a big theater. It was in a small room, but listened and things. But I think that skill is probably becoming, going by the wayside, as we have so many other technologies that I'm sure I don't listen to hearts quite as well as, cardiologists from the 1950s did.
Yeah, I remember when I was training, and this was in the 1970s, we would have these great cardiology diagnosticians who would listen to the heart, feel the heart impulse, and they would tell you everything about what was going on in the heart.
Yeah.
Now we just get an ultrasound, and
Right.
we probably know more.
Yep.
So Dr. Grunwald had some early work that I thought was pretty important. We probably know that now that it's even more important than they thought then. We always talk about something called CRP, C-reactive protein, and how it's a predictor of heart disease and how it goes up when you have inflammation. So he was one of the first people to discover that in heart failure patients, CRP was elevated, probably because they had some degree of inflammation. Mm-hmm. So again, this is dating back to the 1950s. One of his students and one of his researchers, someone named Paul Ridker at Brigham and Women's, has now done extensive research on the value of CRP. And it all started back here in the 1950s. One of the things they tried to do is they tried to measure pressures in the heart, and it wasn't so easy then. We're talking about the first catheter being put in the heart in 1929, and better catheters really didn't develop until the 1960s. Well, he was on the forefront of this, working with the doctors who were designing the catheters. When I was training, one of the most important catheters was a Soanes catheter. There was somebody named Mason Soanes, and he developed a catheter that could fit into the coronary arteries, and it was kind of a one-size-fits-all. You'd put the catheter up, and you'd have to twist it and turn it to get it to go to one artery, then to another artery. And actually, that was also a bit of an accident that he discovered that you could put a catheter into an artery. He had a catheter sitting in the aorta just above the heart, and it accidentally, during a picture of that what's called the aortic root, which is the part of the aorta just above the heart, when he was injecting dye into there to see what that aortic root looked like, the catheter accidentally went into one of the coronary arteries because it sits right nearby. And lo and behold, nothing happened to that patient, but he did get a beautiful picture of the coronary arteries. So that convinced people that it was safe. Just thinking about how difficult it was to do some of these things. Years ago, when we wanted to figure out in the ICU what the patient's internal heart pressures are, because we need to do that, we need to know that to treat them. We would put a catheter into a vein, it would go up to the heart and out to the lung, we'd measure pressure, and that number that we got in the lung, the pressure in the lung, would tell us how bad their heart failure was. Well, this was totally different back then. Dr. Grunwald and his associates back then, what they were doing was to measure this pressure called the left atrial pressure. They were actually having patients lean back, putting a bronchoscope, so they were putting a scope into the airways down to the lung, because where the bronchus divides into the right and the left side, if you put a needle through the bronchus, immediately behind that is the left atrium, and they were doing that to measure left atrial pressure.
That seems nuts.
Crude, but it was an important measurement to have, but certainly a crude way of getting it. But they had no better technique at that time. So he went from doing this early work, while he was a resident. He then went to probably the most important research facility in the United States in the 50s and 60s, and probably now, the National Institute of Health, which is in Bethesda, Maryland. There he developed what people like to refer to as the triple threat. If you're a basketball fan, that the sort of crouch position when you have the ball and you're bending, you're a triple threat because the defender doesn't know, are you going to pass, Are you gonna cut to the basket, or are you gonna shoot? So that's the triple threat. But at the NIH, they developed this different kind of triple threat. So you would be a clinician because patients were coming to the NIH, so you would treat them. You would also do research because they were coming there with very, very interesting things. And you would also teach because you had fellows in training at the NIH. So it would be the clinician, the researcher, the teacher. So here's some of the things that he did. He was on the cusp of development of valvular heart disease and how to treat it. The first valve replacement was done in the 1960s. I believe that was an aortic valve replacement. That's the last valve that blood has to pass before it gets out of the heart. So usually the valve can get stiff and you have to replace it. One of the surgeons at the NIH said, I could replace the valve, but you've never told me if replacing the valve is going to make this patient better. Is it going to make the patient live longer? And Grunwald said, you're absolutely right. We can tell you all kinds of things about what the pressure is across the valve and how tight it might be and what it looks like, but we've never been able to tell you if replacing it is a good thing to do. So he started what's called a randomized study. Some people got surgery, some people didn't, so you could see who did better. And the patients with valve replacement did better, but this was kind of the beginning of what we call evidence-based medicine. You do a study to find out if you're doing the right thing. He also had a big interest in research on myocardial infarction or heart attack, and that's been one of his major areas of research. Some very interesting things in this. There's something in our bodies called this carotid sinus. It runs right by the carotid artery in our neck. And if you massage that, you lower the heart rate. So we know now that if you lower the heart rate, you take the workload off the heart and you reduce heart symptoms. And they discovered that. One of the researchers said, well, if I rub here, the bad changes on the EKG go away. And as soon as I stop rubbing there, they come back. So they devised a system, which I learned about in this book. I'd never known about this. They developed a system to pace the carotid sinus. So that if you were having chest pain and there were changes on your EKG, they would try to develop this pacemaker to pace the carotid sinus and reduce your symptoms. That really never took off because bypass came down the road a short time later. The first bypass was something called the Vineberg Procedure, where you would take the mammary artery that runs along the breastbone, you would pull it away from its attachments, and you would plug it directly into the heart muscle. So it wasn't truly a bypass where you went around a blocked artery, which is the way we typically use what we call the lima or the mammary artery now. You pull it away from your attachment and you put it away from its attachment and you plug it into one of the arteries of the heart beyond the blockage, so it's a bypass. It's like 495 going around Boston. But this Vineberg procedure is very elementary. You just take the mammary artery and connect it directly into the heart muscle. It helped a little bit, but not that much. The first bypass operation was actually done in 1967. Someone named Rene Favaloro. And it worked well. And that was really the beginning of it, and it's just taken off incredibly since then. But one of the things that was studied is, and I think Grunwald was part of this, is bypass always the right thing to do? If you have a patient with blockages, you just immediately go to bypass. And I think we found out over the years, if you have somebody with blockages, but they're stable, you don't necessarily have to go to bypass. You can treat with medications. You can consider stents and angioplasties. There's another major class of disease that he was part of development of treatment. I know in your program, there's a specialist there, something called hypertrophic cardiomyopathy, where the heart's just too thick. And it kind of gets in the way when it squeezes. It blocks the outflow of blood from the heart. They didn't know about this then. They assumed it was the valve because the aortic valve sits right near there. So he had actually sent a patient with this hypertrophic cardiomyopathy. He had sent him to surgery for a valve replacement. And he found out the valve was okay. It was just that below the valve, there was a very thick heart muscle. It was functioning just like a stiff valve, just getting in the way of the output from the heart. And just like a lot of us in medicine, he beat himself up pretty badly, having sent a patient to surgery who didn't clearly need surgery.
Or not that surgery anyhow.
Yeah, so now there is surgery for that to cut away some of that heart muscle so you can open up the tract and let blood flow out of the heart. He also spent a lot of time treating another major illness called congestive heart failure, which accounts for many admissions to the hospitals now. He helped us learn about these words that we use called preload, afterload, chronotropy, inotropy. Basically, it means is there enough of a pressure head to get blood into the heart? Is the heart working against too much resistance? Is it going too slow? Is it going too fast? So he was on the forefront of all of those things. He also, around this time, began work on all the textbooks that he's associated with now. He was asked to edit a section of a textbook for cardiology, and he eventually became the person who took over the entire textbook. We now have Grunwald's textbook of cardiology,
it's
which is
probably the leading text for cardiologists.
Yeah. So there were a couple of people that he respected quite a bit who were doing this before him, but the people who were editing the book had him come in and interview. And one of the interesting things at the interviews, I said, there's something called Carcinoid Syndrome, which is really more of almost an endocrine or metabolic disorder, but has a lot of cardiac effects. So they asked him, where are you going to put this in the cardiology chapter? And he said, I don't think it's a true cardiology disease. I think it's a metabolic disease. I would put it with the metabolic diseases. And they liked his answer. So he got more and more involved with textbooks, and really now is the editor of the major one.
Is he still, excuse me, is he still actively doing that? Or?
He is, and actually, despite his age, he's been on the forefront of some online cardiology textbooks, because he knows the textbooks are pretty cumbersome, and people want to just go online. So there's an online textbook that people can use. So he went from the NIH. He always seemed to be a little ahead of the curve. He went from the NIH. He was asked to start up a medical school in San Diego, of all places. So he went out there for a couple of years. Couldn't beat the weather out there, as we're sitting through another snowstorm today. But he was out there for a couple of years and set up a very nice cardiology center in San Diego, at the UC San Diego. He was eventually lured back to Boston in 1972. At that time, the Boston hospitals, Mass General, Brigham and Women's, they weren't necessarily the forefront of cardiology. They were great in lots of things. He really reorganized the program. He turned it from a good program into the premier program for cardiology in Boston. And he became the chairman of medicine at Brigham and Women's Hospital. So he was really instrumental in a lot of things in Boston. A couple of things that I thought were the most interesting is, we now get all our information for what's called clinical trials. You want to decide if a particular intervention that you want to do is going to work well or not. You take a lot of people with the same disease and you randomize them. So in other words, people with coronary artery disease, you take half of them, you give them one medicine, the other half get either a placebo or another medicine, and over a period of time you see who does better. The researchers don't know who's getting which medicine, the patients don't know, the nurses involved don't know, so those are called randomized clinical trials. And the group of trials that he is most associated with are called the Timmy Trials, T-I-M-I. And that stands for thrombolysis in myocardial infarction. This started in the 1970s. One of the first, the reason it was called the Timmy group is one of the first clinical trials we did in this regard was using clot busters to treat heart attacks. People would come in with certain types of heart attacks, and we would know that there was a blood clot in an artery totally blocking it, and we wanted to break up that clot so we could get blood flow and restore blood flow to the heart. The way we had to do that was clot busters. There were two major ones. There was one called TPA. There was another one called streptokinase. We didn't know which was better. So one of the first clinical trials was comparing those two. And we found out that TPA was better. It's gone on from that first Timmy trial to, I think we're up to Timmy 50 or 52.
50-something,
Yeah, we're way up there. And we as a group have been involved in some of these. One of the Timmy trials was what's called Improve It, and another one called Prove It. And those were to see which cholesterol medication would be the best and which strategy would be the best. and how low should the cholesterol be. So these have all been done through randomized clinical trials. And he started this Timmy group. He's such a famous cardiologist and such a good organizer of these research teams that he was able to recruit people from all over the country to be part of the Timmy Trials. So I think that's one of the things that he's best known for, is the Timmy group. In his later years, after he'd finished a lot of his research, he was asked to be the chairman of a committee, it ended up being called the Grunwald Committee, about how medical device companies and pharmaceutical companies, how they relate to physicians. So he chaired the committee, came up with a set of rules about how we should avoid getting too cozy with these companies because they don't want to be overly influenced. One more thing I'll just say very quickly. There's something called the Citation Index, which is essentially how often your work is cited in major medical journals. If you're a Nobel laureate, you usually get a score of about 62, meaning that's how often you're cited in major journals. A thought leader nationally might get 45. So his number was 187. Because his work wasn't just, quick, let's throw it out there kind of work. It was in very meaningful journals, and lots of people read it and cited it. So, I think he's an incredible guy. He was a very hard worker. He really changed the landscape of cardiology over the last 50 years. And whenever he goes to a meeting, it's like E.F. Hutton, that money management company. When E.F. Hutton speaks, people listen. Yeah. Well, when Grunwald speaks, people listen. Yeah. So I thank my colleague Tom Lee for writing the book that I enjoyed so much.
Great. Well, thank you. For me, obviously as a cardiologist, that was a very neat story to hear. So hopefully our audience enjoyed that. So thank you for telling us about Dr. Grunwald. And with that wraps up another episode of Matters of the Heart. It was brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. Thank you.